Hi, this is Lauren Rona.
And I'm Justin Evans from Dallas Emergency Medicine, and welcome to our 5-part series, Billing and Coding, the reimbursement basics for emergency physicians and what you need to know. This is part 2 of 5-part series.
In part 2, we'll review ICD-10 diagnosis codes and the importance of listing comorbidities. At the end of this review, you should be able to explain the several elements needed for your primary diagnosis.
And you should know the importance of listing comorbidities to support a higher level of complexity in medical decision making.
At the end of my history and physical, can I just write down a simple diagnosis? And what are these ICD-10 codes anyway?
Your best practice, after doing all the hard work of a complete history and physical, is to list your most likely of probable diagnosis. Follow that listing with any comorbidities. You have a pretty wide choice in ICD-10, a listing of the codes kept and controlled by the WHO, World Health Organization. And here is an ICD-10 code book with all the listing of the codes. It is updated at least yearly, but as a practicing clinician, there isn't a need to own one of these books. Well, unless you're hardcore. Let's look at a few cases to illustrate these points. A 25-year-old woman presents with abdominal pain. Do I just write down abdominal pain for my impression or diagnosis after I've finished my history and physical?
Abdominal pain might be easiest, but your best practice, after doing all the hard work of a complete history and physical, is to list your most likely diagnosis. Or, if you aren't certain or don't want to be too specific, list the symptoms or signs. Right upper quadrant pain might be a good choice in this young woman with localization to the gallbladder region. It's a good habit of describing the location of the abdominal pain if you use that for a diagnosis. Epigastric pain, left upper quadrant pain, right lower quadrant pain, and so on. The best practice is to be specific with your impression and add any comorbidities. So, for a 25-year-old female with right upper quadrant pain, adding the fact that she has tachycardia along with a history of insulin-dependent diabetes clarifies the fact that this workup is complicated.
Comorbidities can include abnormal vital signs, although you may want to add that in your impression or primary diagnosis, though either method is fine for coding. And don't forget any other chronic diseases the patients may have. All the comorbidities help the coders identify the complexity of your medical decision making.
Here's another example, the case of a 55-year-old male with chest pain and a history of hypertension and high cholesterol. Presents with associated pain radiating to the left arm, diaphoresis, nausea, vomiting, and dyspnea.
This patient's ECG reveals a classic inferior acute myocardial infarction, or an ST elevation MI. A STEMI. He is taken to the cath lab with confirmed right coronary disease and receives a coronary stent. A diagnosis of acute inferior myocardial infarction is perfectly adequate in this case. Adding his comorbidities of hypertension and hyperlipidemia is appropriate. However, there is no need to also list arm pain, diaphoresis, nausea, vomiting, or dyspnea as other diagnoses, since these are considered typical symptoms caused by the primary diagnosis of acute MI or STEMI. Adding those nonspecific symptoms in this high-risk diagnosis really doesn't add to your medical decision-making. Plus, it takes time and makes the emergency physician less efficient. Who wants that?
Finally, here's example number 3, our last example. A 15-year-old male presents with vomiting.
Physical exam is negative, but lab abnormalities are identified.
The BUN and creatinine are elevated, and the urinalysis reveals a high specific gravity at 1.030.
IV fluids for rehydration and IV ondansetron are administered, and the patient is hospitalized. A single diagnosis is not your best practice, since it may appear to the coder and to the insurer that you decided to admit a simple case of vomiting. Adding dehydration to your diagnosis list with acute renal injury would be a better practice. Unlike an acute MI or dyspnea, radiation of pain, or vomiting might be typical and does not need to be listed. Here, vomiting along with dehydration and acute renal injury should all be included in your diagnosis. Remember, that will help the coder and insurer understand your reasons for hospitalization. Listing vomiting alone is too vague.
We'll finish part 2 by focusing on a debatable point. Are adding mechanisms of injury useful and necessary? Should the emergency physician add diagnoses that are not related to the chief complaint?
Let's look at some of these, simply because many are just too entertaining to ignore. But I don't think we can answer the question about appropriateness in all emergency department presentations. I'm afraid the provider will have to use their judgment. We can note the many critics of ICD-10 believe emergency physicians' time should not be consumed by documentation for epidemiologic reasons.
Some ICD-10 codes make sense and are logical to include, like motor vehicle traffic injury, which is V89.2.
While other codes, though entertaining, don't really add much to treatment, such as bizarre personal appearance, R46.1, which might apply to a large number of patients and non-patients alike.
Kind of like you, Justin.
Lady Gaga and her meat dress come to mind.
And on the list goes, well, into the hundreds. And though amusing, listing these in your diagnosis codes can take considerable time and effort while not adding to your reimbursement.
That's probably enough for now. Let's review.
List your primary diagnosis as your most likely diagnosis, which is the reason for the emergency department visit.
If you can, be specific in your diagnosis. List acute inferior myocardial infarction instead of chest pain. And remember, there is no need to include symptoms that are typically associated with your primary diagnosis. You don't need to list chest pain, nausea, or dyspnea with acute MI.
But when there are symptoms that may not be typically associated with a diagnosis, you should include those. So, with a patient who presents with vomiting and also has dehydration with acute renal injury, list those too. And don't forget the comorbidities. Adding these indicates complexity in your care and decision making and helps document your higher levels of risk and care. That's it for now, folks. Thanks for watching and stay tuned for more episodes on billing and coding, the reimbursement basics for emergency physicians, and what you need to know.
Signing off from Dallas, Texas, this is Justin.
And Lauren.
And here's an ICD. All right. Okay.
Stop, just.
Okay.
I'm sorry. Okay. I can't look at you.
IV fluid. Stop it.
I'm not doing anything.
I know.